Okay, this goes with the last group of PowerPoints. The first part should be a review of sympathetic nervous system medications, because we talked about those with cardiovascular unit as well as the respiratory unit. So we know that sympathetic nervous system medications use adrenergic receptors, which are alpha or beta receptors. We know that adrenergic agonists stimulate the alpha and beta receptors to act like the sympathetic nervous system. So our sympathomimetic, and things that block the sympathetic nervous system are anti-adrenergic, and they're going to be closer to the parasympathetic nervous system then because they're blocking the sympathetic nervous system. So our receptors are alpha and beta, and an adrenergic would be an alpha agonist, and those alpha receptors are, hopefully you're yelling out the answers, you know how I got when you guys are really quiet. The alpha adrenergic receptor we talked about was in the nose. And so those two medications were on your exam today, so hopefully you already know this, were oxymetazoline and pseudoephedrine. I am envisioning you yelling those out because you know how that makes me cry when you don't remember. And then the beta receptors that we were talking about are in the lungs, and we just learned about those medications earlier. The beta adrenergic receptor, or the medication that acts like the sympathetic nervous system in the lungs, is albuterol. Open the nasal and lung passages so it's easier to breathe. Now, anti-adrenergic, we're talking about alpha receptors. The other area of alpha where we know that alpha receptors are, which you better be answering correctly at home, is the blood vessels. If we block the alpha receptors on blood vessels, then we stop vasoconstriction and decrease the blood pressure, and that medication was doxazosin. And then the beta receptors were in the lungs and the heart, and that's the ones we were most talking about on this side for cardiovascular. The beta blocker, or the anti-adrenergic, is metoprolol, which decreases heart rate and decreases strength of contraction. And that is what decreases blood pressure because we affect blood volume. So we talked about medications that affect the sympathetic nervous system, or sympathomimetic medications. You have to use cautiously in glaucoma. You have to tell people about dry mouth, about driving, about hypertension, potential coronary artery disease. You have to also be sure potentially that those benign prostatic hypertrophy people are okay. But this side, we're bringing the heart rate and the blood pressure down, so we might, and the strength of contraction, so we might have to worry about people with CHF. We still have to worry about the benign prostatic hypertrophy people, and we have to worry about asthma. So that should be a review, because we talked about all these medications, and this goes with the other lecture about contraindications and teaching. So that should be a review. So the medications that we will talk about now are ones that affect the parasympathetic nervous system, and we haven't talked about those really. So the neurotransmitter, remember, is acetylcholine, and the receptor is cholinergic. So if we stimulate, we are a cholinergic medication, and if we block, we are an anticholinergic medication. So the cholinergic medication that we're going to learn about is called Baclofen. And this medication is used for people if they have urinary retention. Because remember, so urinary retention means the bladder is full of urine, but since the bladder muscle isn't contracting, then the urine can't come out. But the parasympathetic nervous system causes the bladder muscle to contract. And so therefore this is a treatment for that, for urinary retention, especially maybe after surgery or something. So this is oral or something. But then when you look on that slide, it's all the things we talked about for people that we have to be worried about for people who are taking medication that affects the parasympathetic nervous system. So if they have an obstruction that's leading to their urinary retention, like benign prostatic hypertrophy, they cannot take this medicine because it doesn't relieve the obstruction. We have to worry about cholinergic side effects, so maybe looser stools or pupils that are more constricted and don't dilate as easily, so issues with night driving. We have to worry about people who are bradycardic or have asthma, because those are the people that we were worried about, like we said before, with the people who are using medications for parasympathetic nervous system. So if the person gets too much of this medicine, then we can give them an anticholinergic to reverse it. The other side is the anticholinergic medication, and this medication we're going to talk about is atropine. So it looks like the cholinergic, I'm looking at the slides here, the cholinergic autonomic medications, and then it says anticholinergic medications, but that's an error in the slide because that's the same information. So don't look at that. Just X that slide off and go right to atropine, which is our anticholinergic, which is given IM or IV. This medication could be an antidote to a cholinergic crisis, so that this would be the antidote if you took too much bothanocol, or for some plant poisons. It is also part of the ACLS protocol, or advanced cardiac life support, for symptomatic bradycardia. So if the patient's heart rate is low and they're getting symptoms like feeling that they're going to faint or sweaty or nauseous, that's considered symptomatic bradycardia, which means their blood pressure is low. Not everyone with low heart rate has a low blood pressure. Sometimes that's normal. But for somebody whose heart rate dips down, they might feel sick. You can give atropine to bring that up. So we would have to worry again about the people with benign prostatic hypertrophy. We have to worry about the anticholinergic issues, which are similar to the adrenergic issues, like dry mouth, which is why sometimes people use atropine at end of life because it dries up secretions. We'd have to worry about potentially pushing things too far the other way, like tachycardia and hypertension. Generally, atropine is used for symptomatic bradycardia instead of epinephrine because it's similar to the sympathetic nervous system, but not as strong. So someone who's awake, I want to bring their heart rate up without making it go to like 200, which epinephrine would do potentially. So now this last part is talking about medications that affect the somatic nervous system or the voluntary nervous system, which is a nerve that's leaving your spinal cord and it is releasing acetylcholine into the synapse to interact with receptors on the skeletal muscle that will cause contraction. And when it's time to relax the muscle, some of the acetylcholine will be recycled through the process of reuptake, and some of the acetylcholine will be broken down by the enzyme in here called acetylcholinesterase. So, I lost my marker, hold on. So, one condition where this can be altered is an autoimmune disorder called myasthenia gravis. And in that disorder, your autoimmune system breaks down these receptors. So you don't have as many receptors on the skeletal muscle, which means when your body tells your muscle to move, this still works, the nerve still works, sends the acetylcholine out to interact with the receptors. But if there's less receptors than there's supposed to be, then the person will have muscle weakness and increased muscle fatigue. So they'll have decreased muscle strength, easy fatigue, and eventually some of the very important muscles will be affected, such as the muscles that help with breathing or the muscles that are important for swallowing. So you can give a medication to help this condition. And the medication affects this enzyme, acetylcholinesterase. The thought is that if you block this enzyme, then acetylcholine will stay within this synapse longer and will be able to interact with the receptors that are left longer, which means you could potentially increase the strength of contraction and decrease muscle weakness for patients with myasthenia gravis. So, if a person has myasthenia gravis, then you would put them on a long-acting, what would be considered a cholinergic medication. This cholinergic medication is really meant for the somatic nervous system, but we know that there could potentially be crossover into the parasympathetic nervous system because it's the same receptors and the same enzyme. So that's what we have to be thinking about. So if we want to put the patient on a medication for myasthenia gravis, we have to be sure they have myasthenia gravis. And one way to do that is to use a medication called endonorphium, which is a very, very short-acting medication given in the IV to see if the patient actually has it. So if the patient has myasthenia gravis and you give the patient IV endonorphium, their symptoms should go away. They should have increased strength of contraction, less muscle fatigue. Then the medication wears out in 15 minutes and their symptoms go back to where they are. And so then you know that they have myasthenia gravis. So there will be questions on the exam, meaning what are the results of this endonorphium? If I give endonorphium and there's no change in the symptoms, then the person doesn't have myasthenia gravis. They have a different problem. And they won't benefit from the long-acting treatment, which is pyridostigmine. So pyridostigmine is a medication that's taken by mouth, and it's used to affect the activity in this area, in the somatic nervous system, but because it's possible that there'll be cross-action, you can't use it with people who have obstruction in the intestine or the urinary tract system. As it's cholinergic, it's like the parasympathetic nervous system potentially would increase bowel contraction and bladder contraction. If the person had too much of a cholinergic agent, just like we said before, atropine is the reversal. If the person is on pyridostigmine for their myasthenia gravis and they're not toxic, they haven't taken too much, then they shouldn't take anticholinergic medications as it will block the effects of the medicine they're on. So just to be sure we have this down, we're back to that grid that we drew. Adrenergic, anticholinergic, sympathetomimetic, or medications like the sympathetic nervous system, are similar to medications that block the parasympathetic nervous system. Medications that are like the parasympathetic nervous system are similar to medications that block the sympathetic nervous system. So these groups of medications have similar side effects and contraindications. That's what we talked about the last lecture. What I wanted to add, now that we've talked about myasthenia gravis, is that anticholinergic medications, myasthenia gravis, that's the only category of medications people with myasthenia gravis have to avoid. I wanted to be sure you saw that this is a special thing. Because if someone has myasthenia gravis, we're trying to increase action at cholinergic receptors. And if we block cholinergic receptors, then the patient will have a problem. But it's only cholinergic receptors. It doesn't matter what's happening with the alpha and beta receptors because that's not part of it. So that's why myasthenia gravis is by itself. So be sure you understand that. Okay, two more medications to talk about. And they're medications that will be for muscle spasticity or muscle spasms. So, again, when it's time to move, the brain sends a message to the spinal cord, and then the nerve exits the spinal cord, releases acetylcholine, which interacts with cholinergic receptors that causes calcium to go in the muscle and causes muscle contraction. That's how muscles are supposed to work. And there is a picture on the slides of what happens when calcium comes into the muscle cell that pulls the troponin caps off the actin beads so that actin myosin can interact and shorten the muscle fibers. So sometimes people will have involuntary contractions of their muscles, which can cause pain. And it is a normal response of the body to do that when there is a joint injury or some kind of problem, arthritis or malalignment or something. The muscles will spasm on purpose in order to try to keep the bones aligned. So commonly when people have a skeletal issue, that'll go with a muscle issue. So if the patient has involuntary contraction of muscles causing pain, you can give them a muscle relaxer, and those muscle relaxers are really a general category that could either be centrally acting or peripherally acting. If it's centrally acting, that means it's affecting the stimulus from the nerve itself. So a centrally acting example, or our prototype, is Baclofen. If it's peripherally acting, it's acting on the muscle itself, and our prototype is Dantrolene for that. So oftentimes people can use either class for similar symptoms. What Baclofen does is way up here, the brain was sending a message to the spinal cord, and the spinal cord peripheral nerve went down to the muscle. It stops it right here. If we never stimulate this nerve exiting the spine, then we don't release acetylcholine and the muscles don't contract. So it decreases especially very spastic reflexes. So Baclofen is really good for people who have multiple sclerosis or spinal cord injury or something like that. It'll decrease those hyperspastic responses. However, because it's working up here in the brain and slowing nerve impulses, it can cause drowsiness, weakness, fatigue. It's decreasing muscle activity, so it could affect other smooth muscles, especially in the GI tract and the GU tract. It's sedating, so we have to be careful about medications that are also sedating, like opioids, histamine blockers, clonidine that we talked about, alcohol. All those things will have an additive effect, not a synergistic, additive, on top of each other to increase sedation. So Baclofen can be given in multiple routes. It can be given orally, and it can be given intrathecally. So someone who has chronic spasms or pain after a spinal cord injury can have a Baclofen pump inserted, and it actually continuously gives Baclofen into the spinal cord to prevent the painful spastic muscles from doing, that kind of activity. So anyone on these medications, though, needs to withdraw slowly if they decide that they don't want to be on them anymore. So if you're on oral medications, then you have to taper off 1 to 2 weeks. The same if you're on intrathecal medication, you have to slowly taper off before you stop the infusion all the way. Because if you stop the medication orally without withdrawal, the person will go through withdrawal syndrome, which would include anxiety, seizures potentially, restlessness. If you abruptly withdraw medication from the intrathecal pump, the patient could have fever and muscle damage and could end up dying. So you have to be careful about that. But it is very, very effective treatment for people with chronic muscle spasticity, especially after a spinal cord injury. And then the last medication we're going to talk about is called Dantrolene. And this is a direct acting, peripherally acting muscle relaxer because it blocks the release of calcium here So we allow the nerve to release acetylcholine interacted with the receptor, which is normally supposed to cause calcium to go into the muscle to cause contraction, but we don't allow this to happen. Therefore, the muscle relaxes. It can be given PO or IV. Its side effects, of course, would be weakness, dizziness, nausea, kind of the same types of things that occurred with the other type. Less sedation because it's not working centrally, but it's still possible. It does potentially cause hepatotoxicity, which you'll remember could cause abdominal pain, predominantly the right upper quadrant, nausea, vomiting, anorexia, jaundice, white stool, dark urine. Blood tests that would change would be the liver function panel. IV dantrolene is a special emergency drug that is used in the operating room. So I'm not sure if you've heard of this, but it's called malignant hyperthermia. There are some people that react to anesthetic agents by causing a continuous muscle contraction, and that contraction brings the temperature up to temperatures like over 106, which is very bad. The brain cannot survive with that much heat, and it'll start to damage the muscles. So that's an emergency. So dantrolene is an IV medication that can be given to stop that contraction and bring the temperature down. It's an emergency treatment for malignant hyperthermia. I've only, as I told you, I'm old. I've only had to do this once for a patient who developed temperatures of 105, 106 after surgery. And they had to be on it for several days in order for the reaction to calm down. So now you've hopefully taken the exam. We got through that mostly. You listen to the lower respiratory tract medication. You listen to the organization of the nervous system and neurons and how medications affect neurons. You listen to how a review of this adrenergic and anti-adrenergic medications. We talked about cholinergic and anticholinergic medications. We talked about cholinergic medications that were specifically used in the somatic nervous system. And then we talked about muscle relaxers that were both centrally and peripherally effective. Next class, the day or two before, again, I'll send out a schedule for you to tell you, what you can expect at what times, what are the little activities you have to do between lectures, when you have to check in and check out. The discussion board is now open. Remember, you have to go to week 8 in order to find it, because that was the one I was supposed to set up before I left for Cuba. And then do the ATI for Neuro Part 1. And for next class, again, you'll have to check in, say, hey, I'm here. I did that ATI in order to get the password for the quiz. And the quiz will be only 10 minutes, the first 10 minutes of class. So if you don't check in on time and you haven't done your ATI, then you might not be able to take the quiz, just like how we would do in regular class. So have a good week. I will check my email daily, but only once or twice a day. I can't, the amount of emails that come through now that we're all at home is a lot. So in order to not overwhelm myself, I'm only checking it at 8 and 5 o'clock and not as much on the weekend, because right now that's when I'm working in the hospital. I don't know if I'm going to have to work more. So just so you know what your expectation is to get a response from me. All right, take care.